title of my talk today, Care Considerations for the Management of Substance Use Disorders in Rural Primary Care. I'll talk a little bit about my experiences just in practice and working really with learners, with residents and medical students is probably my biggest passion, especially those that are aiming to go into rural practice. So I'll touch a little bit on kind of some of the approaches we've taken here in Belleville and in the surrounding community, and a little bit of the landscape of the rural disparities that exist, and then hopefully leave plenty of time for some dialogue and questions at the end. As Randy mentioned, I've been here just over 5 years as core residency faculty at the Belleville Clinic, which is one of the 4 residency teaching sites in family medicine. And I am pretty recent to kind of the addiction medicine team. I took the exam last year and have started doing some consults about 4 weeks out of the year at UW on the AODA service there, which I've really enjoyed a lot. So yeah, let's dive in. One of my hats that I wear with the residency is getting to work with something called the Rural Health Equity Track, which I direct. It's a program that started when I joined as faculty, and it basically involves half of our residents at the Belleville Clinic. So we have 6 residents total that plan to go into rural practice, and we try to get them as much experience to support that interest and be successful, really being leaders in their rural communities when they get out into practice, and good patient advocates. So Belleville, for those that aren't familiar, we're about half hour south of Madison, more or less still out in a cornfield here, but a quick trip just went up, and a car dealership in the past few years. So becoming a little more suburban feeling, but we serve a pretty rural population that drives from various parts of southwestern Wisconsin. As part of the Rural Health Equity Track, our residents do quite a few weeks, at least 22 weeks of rural rotations in the area. And then we do health equity focused workshops throughout the year. We attend rural national conferences together, things like Doctor Day. And some of the experiences that we've focused on them getting as part of the curriculum and their clinical practice at the clinic here and on their rotations involves some targeted addiction training. So there's great didactics that Randy and a lot of the addiction faculty are involved in leading. But we have a pretty substantial panel of patients with opioid use disorder and other substance use disorders here at our clinic. So we really want our residents to come through feeling comfortable with MOUD, hepatitis C treatment, with substance use disorder prevention, screening, and treatment in general, medications for alcohol use disorder, and treatment of outpatient alcohol withdrawal, I think are all really important skills to have as a rural family physician, regardless of what your practice looks like. And I'll talk a little bit about our MOUD practice here as we go along. So a little bit about just the landscape of rural disparities. In Wisconsin in particular, these things probably aren't too surprising, but the population to primary care physician ratio is substantially worse for rural counties versus urban, with the numbers there on that first line. Dentistry is a huge barrier for patients, with very few dentists that accept Medicaid in rural parts of Wisconsin. And then population mental health care providers is a huge disparity. The one that I think I struggle the most with, honestly. Psychiatrists and therapists, very hard to come by. Uninsured adults, so higher rates of uninsured adults and uninsured children in rural counties in Wisconsin as well. And just looking at chronic disease and health outcomes in general. So when you look at, if you line all the counties in Wisconsin up our 72 counties. The ones with the worst health outcomes are the rural counties. So, and especially in the Northwoods, in the northern part of the state, that makes up the bulk of the counties that are doing the worst in terms of health outcomes. I'm not going to break down all the different substance use disorders and prevalence rates in rural versus urban here, but I think important to call out a few important disparities that exist. This was a graph from a JAMA article this year that looked at opioid overdose deaths based on urbanicity, and rural counties. This is national data. In general, the total number of opioid overdose deaths has tracked lower for a number of years in rural versus urban counties. But on this slide, something I think is particularly concerning that relates to this fourth wave of stimulant use is the acceleration rate of opioid overdose deaths in rural America. So that green line there, if you look to the right of this graph, we've seen a rapid acceleration in the number of opioid overdose deaths, largely related to methamphetamines. And the rates of methamphetamine use and overdoses related to methamphetamines are significantly higher in rural areas. So something to pay attention to. I think important to think about the shift in demographics that's happening in rural America in terms of people of color and indigenous populations growing faster than other groups in rural areas. So we're seeing in the most recent census, the number of people of color in rural America was up 3.5%. And with that, if you're a person of color or an indigenous person living in a rural area, you're more likely to face certain disparities, important disparities compared to if you live in an urban area. So you're more likely to have a lower income and higher unemployment. You're less likely to have a high school or college degree, a higher burden of infant mortality, less likely to have health insurance, or more likely to forego care, less likely to have a PCP. And then there are some lower prevalence rates for people of color in rural areas in terms of smoking and binge drinking. But I do think that sometimes we look at those prevalence rates, and I think there's a common perception that people of color don't struggle with these issues in rural areas as much. And so there's subsequently less outreach efforts going on. I've seen that come up in numerous meetings I have with community partners where doesn't feel like there's a need to offer Spanish speaking services, for instance, because that group doesn't have the same rates as the white population. So in terms of, barriers and challenges, they're numerous in terms of finding resources and supporting recovery for people for substance use disorders. It can feel overwhelming, but there's, I think, such great reward in doing this work and connecting people where we can. We know that of people with substance use disorder diagnosis, only 6.5% receive any treatment. And most of the people who don't receive treatment because they aren't seeking it, don't want it. But access and stigma really make up a big portion of the rest of why people with substance use disorders don't receive treatment. And access and stigma are huge barriers in rural areas. So, and the other thing I'll say is just that people in recovery and dealing with substance use disorders really have just less of what is needed in general to support recovery. So housing, such a struggle. I know in Southwest Wisconsin, there's just such little access to affordable housing and very few shelters. And for people who have dealt with legal challenges in the past, past jail and prison time, or are struggling financially, there's just very few options. I serve as the AODA medical director for Greene County, and it's just one of the biggest struggles we face with our drug court clients is finding housing. Transportation, don't have to tell you all, the price of gas is crazy, and there is really no public transportation in these areas. VEO, I'm surprised it took me so long to learn about VEO, but recently did, and so trying to get more folks that benefit to help with the cost of gas and mileage. Employment, there's higher poverty rates in general with lower employment and education options. Child care, very little to no affordable child care. And food insecurity is I think, a major one that a lot of people don't think of. With 20% of rural households living in food deserts compared to 6.1% of urban households. And grocery prices are actually quite a bit higher in rural areas, 4.2% higher. Something that's being worked on in Wisconsin over the past few years is broadband access, but we're really not quite there yet. 25% of the rural population in our state lack access to high-speed internet. I know that I almost never do video visits with patients because so few of my patients have a good enough connection to do that. So, we do a lot more phone visits than video. And we know that at least half of patients in treatment for substance use disorders receive some form of telemed. So doing it via phone versus video does have some downsides. Silos of care and lack of care coordination. Oops. I think it is something we all are very aware of if providing care for substance use disorders. And it's, I think, just much worse in rural areas from what we know, with, difficulty communicating across different systems, healthcare systems. So having patients work out of multiple regional, smaller healthcare systems, coordinating between mental health providers, county-based treatment, all of these different silos of care are really challenging, getting records on patients. And then I think, and a lot of the evidence has shown that rural hospitals often have providers that are less comfortable with offering treatment for addiction, and we often see patients taken off medication or maybe not offered resources that we'd like to see offered, or linkages from the ED for patients who present after overdose or in withdrawal, not happening to the degree, or just the degree we'd like to see, or opportunities missed as far as getting patients started on effective medication. Specific medication options are pretty limited in a lot of regions. Methadone clinics, I've got an OTP map on one of these future slides here that I'll show you, but there's a lot of areas that don't have an OTP within driving distance. Sublocade access, I think, is increasing, but we don't have it in my clinic due to some some barriers in the system of getting it started in our workflows, but hope to in the near future. In terms of pharmacies stocking buprenorphine formulations, run into challenges with Subutex pretty often. And then just access to kind of continuum of care, including recovery housing, is very limited. Concentration of most of the treatment programs when it comes to IOP and inpatient is in the southern half of Wisconsin. Stigma and confidentiality concerns. I encounter this a lot with patients, as I'm sure a lot of you do, that, and with colleagues and staff. around, especially around MOUD, and concerns about prescribing it, or if I start offering MOUD in my practice, I'm going to be inundated with patients, and I don't want to take that on. If we don't have behavioral health in-house, then we're really not in a position to be doing that. So that's a big, I think, barrier to try to continue to break down and have conversations with colleagues around. Harm reduction services. So this is kind of a challenge that conversation I've continued to have in our region around needle and syringe exchange services. And there's a lot of community and even law enforcement resistance to bringing that into our community. Patients worry that about confidentiality and anonymity sometimes coming to a primary care clinic for these services. And I think it is pretty pervasive, this stereotype of rugged individualism of just I can manage this on my own. I don't, if I seek help, then I'm weak, and that type of mentality. So some of the other statistics around access to services. So in Wisconsin, as of 2019, it was 21% of Wisconsin counties still did not have a buprenorphine prescriber. I suspect that's improved from there, but I haven't been able to find more recent data. Access to harm reduction services are quite limited in a lot of rural counties in our state. With changes in fentanyl test strip legislation, I think that's expanding. I know a lot of the counties in Southwest Wisconsin now are offering fentanyl test strips and have been able to purchase those through their SOAR funding. Co-locating pregnancy care. So it's a pretty small number of family physicians who provide both pregnancy care and buprenorphine. It's interesting. I think if you look at the numbers, this was from 2020 of OB-GYNs versus family physicians that currently have waivers. It's only 181 OB-GYNs versus 4,066 family physicians. So a lot more family physicians have waivers. And I expected the number of early career family physicians that offer both these services to be higher, but I think it really gets at how much in training programs we're teaching this content, because this study showed that there were actually 15 programs that had graduates that were learning about MOUD in pregnancy. Co-locating hepatitis C care, I think, is another effort we need to focus some energy in our training on, because it's just of great benefit to patients to be able to get that care within primary care, and evidence-based, that it can be treated as efficaciously within primary care as within specialty care, and just super rewarding as well. This is the rates of Hep C among young adults in Wisconsin, and the overall number of new cases on the map on the left is higher in urban counties, as you would expect. But when you look at the rate of Hep C cases from 2018 to 2020, the rate was significantly higher, again, in some of those northern counties. And this is the map of where Hep C providers are located, and the 45-minute driving time outside of those providers. It's a map just showing the OTP locations in Wisconsin. There is one in Minocqua now that doesn't appear on this map. So, and then buprenorphine prescribers as of 2019. This is a map that shows the number of psychiatrists to close the gap in need in the counties throughout Wisconsin. So you can see some counties, it's 5 or more psychiatrists needed to close the gap, meaning that they probably may not have any psychiatrists at all. drug court programs. A lot of counties don't have drug courts. There has been an expansion in number of drug courts in the past few years, but still only 40% have adult drug courts, and 24 have hybrid OWI or drug courts, and 26 have OWI courts. And just a lot of places that don't have a full continuum of services, like I already mentioned. So more unusual to find those. Very few like detox facilities, IOP programs, residential programs, especially in the northern half of the state. And hard, especially I think at the county level, to retain and find qualified staff to work in AODA. There was like almost complete turnover in the county I work during COVID, so lots of new staff. I think there's some great efforts happening in certain areas, especially with the expansion of harm reduction services, Vivent, and LifePoint. Their mobile services has expanded quite a lot, especially the northern part of the state. So that's bringing a lot more needle syringe exchange services and other harm reduction services, other parts of the state. Peer-based recovery support has expanded quite a bit through Wisconsin Voices for Recovery. More counties have hired peer support than in the past. So that's all been very positive. Randy mentioned the RESAs and Substance Use Management Boot Camp series, with some great efforts that are really looking to pull in rural primary care providers. The Marshfield Clinic has a great model with their family health center network of offering substance use treatment within primary care. And then I'm pretty involved with the Wisconsin Collaborative for Rural GME, which is a group that involves program directors and staff from a lot of the rural training tracks and rural located programs in family medicine and other specialties in the state. And it's just been encouraging to hear more programs talk about their MOUD training and substance use disorder training for their residents and students. There's a large medical student, actually an interdisciplinary event happening in a few weeks that's focused on, it's a 3-day workshop focused on substance use disorders. So more and more targeted training seems to be happening within our state, especially in the rural primary care programs. This is just, there may be similar models to this out there, but in New York and I think New Jersey too, they have these health hubs, which I'd love to see more of this in general, but especially in rural areas, they have models that integrate so many services within the same site, and through legislation that allows billing for harm reduction services. As a registered Medicaid provider, that's allowed them to integrate harm reduction into these health hubs, and alongside that provide primary care. So just touch on some of my experiences at Belleville that may be useful for others to hear, but I'd love input at the end too. So we have been offering buprenorphine and naltrexone for a number of years now. Naltrexone since 2017 and buprenorphine since 2018. And as a group of faculty, we all got waivered in 2017 together, and then our APPs the following year. And the residency, the family medicine residency, since that time as well, has been having all residents get the waiver training at the start of their R1 year, and then apply for their DEA and waiver after their R2 year, and have had and really just expanded over time the structured didactics and case discussions that have been in the curriculum. We have resident education afternoons every other month, and I lead a lot of case-based discussions at those around different substance use disorders and management. And I think residents really are always just really engaged in those. A lot of those focus on alcohol withdrawal management and buprenorphine. I think there's directions we'd like to go with our team-based care in the future, but things have worked pretty well up until this point. We have about 60 to 70 patients right now, last I looked, who are prescribed either buprenorphine and naltrexone for opioid use disorder from our clinic. When we started this, we really, it really was important, I think, to have a team lead from the RN team to help facilitate care. And that's continued to be really helpful. It is one of our triage nurses. We have 3 triage nurses, and it takes quite a bit of her time, to be quite honest. And so we've had to kind of continue to advocate that, this is chronic disease management. She needs to spend half an hour or more on the phone with a patient, doing an intake. That's what she needs to do. So we have Jamie, who does a lot of our intake calls, and then helps with scheduling new patients who call with opioid use disorder or really any substance use disorder. She's really passionate about it, so she's been a great champion. And she often will send naloxone or comfort medications if needed during those intake calls. Provides some nice continuity to have her take the lead on things, but all of our other nurses are comfortable with smart phrases that we have for these intake calls as well, and back her up when she's not in clinic on Wednesdays or when she's on vacation. And we do offer, if a patient is not familiar with induction, hasn't been on buprenorphine before, is nervous at all about the process, that the nurse can really help facilitate a telemedicine visit, like a nurse-led telemedicine visit with the patient, and call them during their initiation. The nurses do our naltrexone administration, Sublocade, not currently. And then Jamie does a lot of coordination with county AODA staff and the jail. There's a nice model from rural Colorado called It Matters, where they studied 42 practices and did some really targeted staff training around MOUD that we've kind of borrowed from at times. One thing somewhat unique, I think, because we're a teaching clinic, we've really emphasized that MOUD should be resident-led whenever possible. The residents really need the experience and greatly benefit from really leading this care. And they do a fantastic job. We have them scheduled for a long office visit for intakes, and then we created teams. So patients are paired with 2 residents and a faculty, and sometimes an APP as well. So we present that with new patients, that you're going to be, it's team-based care here. There will be a resident that you're most familiar with, but we want other folks on your team so that you have access to appointment access is a huge part of it. And then we use the problem list often to kind of document between members of the team what's going on or needs follow-up. Do a lot of telehealth for MOUD with offering sometimes every other visit via telehealth. There's so much in terms of transportation barriers that patients face. So we try to be really understanding with that and patient-centered when we can. We do have a behavioral health clinician as of the past few months, but for a couple of years there, we didn't. And so sometimes patients will work with her. I'd love to do group visits. I haven't quite gotten there, but I think it is a model that could really build in some nice peer support, mutual support. So we'll see. And all of the residency clinics have expanded access quite a bit. So I'll just mention that, especially if you work in the area and are looking for PCPs that prescribe buprenorphine, all of the family medicine faculty have waivers now, and as I mentioned, all the residents get training. So there's capacity within all the family medicine residency clinics to take patients. I think there's a need for more RN support in general in our clinic, and a lot of especially rural family medicine clinics, but all the family medicine clinics, and it'd be great to integrate peer support. I think they could really improve things for our patients and provide ongoing continuity. But I think we really need a sustainable funding model for how peers are used in primary care in general. I'll just mention a little bit of how we collaborate with county-based mental health and AODA. So when I will say 4 or 5 years ago now, we started working with Greene County Human Services, and they've been our primary referral source for patients. So we get referrals from their outpatient AODA counselors, drug court. I would say the bulk of our patients come from them and live in the Monroe area. It's been great to get to know them more, and myself and some of the residents, when able, attend our AODA Community Coalition meeting. I think being as active as I can be with community groups, Better Broadhead is one, it's just really helped strengthen our partnerships with them. Mentioned I now serve as the AODA medical director for Greene County, and so I oversee some of the treatment plans for patients, all the drug court patients, hybrid court patients, and help where I can with medication consulting and linkages to care, linkages with the jail. We're trying to increase our collaboration with the local jail and have had a lot of recent conversations with some of the other jails in Southwest Wisconsin. I know I think the grand rounds last month or the month before was focused on this, but there's a huge need to expand medications for opioid use disorder in jail and prison settings, with most of the jails and prisons in Wisconsin not offering this, and we've run into issues periodically with patients being taken off of their buprenorphine while in jail in our area, which is just really hard to see happen. But these rural jails really don't have reentry coordinators either, so often that's, I think, a person that would be facilitating some of the referral to community resources, recovery services, PCPs, and so they just lack the staff is the biggest barrier, and connection to the county-based services to know what's available. We did install a laptop in the jail in Greene County during COVID through a grant from DHS that has been utilized by counselors and peer support from our county. And we're looking into a model where we would use a peer navigator to meet with all inmates who have any identified substance use concerns prior to release, and then help with linkages to primary care and other community resources. So we're hoping to pilot that in the coming months. But the doc in our local jail has turned over 4 times, I think, since I've been here. So it's been really hard to kind of work with them and address some of these challenges we've seen come up with patients as far as continuing buprenorphine or even initiating buprenorphine with that level of staff turnover. So in terms of things that I'm working on that I'll share, a lot of what I'd like to see happen relates to work in the jail, our local jail, and in Southwest Wisconsin, really statewide, in terms of doing more for screening for substance use disorders and helping with transitions of care and buprenorphine initiation or continuation. So that's, I think, really rewarding, exciting to be involved with some of those efforts in our local community. We're doing some work through a grant around community stigma and bias reduction, especially with physicians in some of the other systems in the area, through a grant that Better Broadhead has, looking to hopefully be able to offer Sublocade soon, and maybe down the road pilot some group visits at our clinic, or see if there's ways we can get peer support. So I think in summary, I think there's plenty of time now for questions, but I'll just wrap up in saying, just from the data that I presented, obviously there's huge inequities in rural areas. especially in terms of barriers to accessing services, stigma, and ways to support recovery. But this is extremely rewarding work, and it's just, I think, been probably the thing I'm like proudest of is seeing residents graduate that have come through Belleville, and really all of them that I've interacted with since graduation are treating substance use disorders, treating opioid use disorder, treating hepatitis C. It's great to see that happening. Trying to get out of your silo, get into the community, attend coalitions, have conversations with community agencies has been, I think, really important. Finding ways to co-locate behavioral health, peer support, Hep C treatment, pregnancy care has great benefit. And then getting to partner with community organizations to obtain grants together to address some of these issues has been really helpful.